Hello and welcome. I'm Steve Clemens, editor-at-large of The Hill. Thanks so much for joining us for the second session of our timely and important discussion on the future of healthcare, tackling costs and pathways to care. I'd like to thank our sponsor, Viatris, for its support of today's conversations. In this hour, we're going to hear from a former member of the White House COVID response team, health economists, patient advocates, members of Congress, and more. Before we get underway, a quick reminder, you can tweet us at The Hill Events, but more importantly, the hashtag TheHillHealth. We're broadcasting live, and we'll take your questions throughout the program. As with any live stream, you could experience some trouble. Just push refresh the page, and all will be well. My first guest of this session is Andy Slavitt, former senior advisor to the Biden administration's COVID response team. He's also author of a new, really important and fascinating book called Preventable, the inside story of how leadership failures, politics, and selfishness doomed the U.S. coronavirus response. Wow, it is an indictment. I'm really looking forward to talking with you, Andy. Thank you so much for joining us. First, why don't you give us a snapshot as you see it of Preventable, why you did it. There's been an enormous response, but tell us about it. You're muted, Andy.
Oh, sure. Just the mute button. Well, look, the last year and a half has been unlike anything most of us have ever experienced, certainly in our generation. I think it's important to look at what we could have done better. And I think that's probably true on a few levels. A technical level is sort of the most obvious thing people talk about. What could we have done better at the CDC? But I think we also have to look beyond that. We have to look at two more pictures. One is at the political leadership level, and the other is at the level of what did we as a society do and how well did we do in preventing deaths so that we can get it better next time. And I think there's a lot of interesting things that you've learned in the book, both about where the U.S. now in terms of how it views science, about how different people live their lives, and then a bit of the inside story about what was going on inside the White House, what the Trump administration was trying to optimize for, and how that all played out politically. So a lot of lessons still to be absorbed, an early read on history, and of course, we're still in the middle of it.
Well, look, one of the reasons I'm so pleased that you did this book, and I hate to be so stark, but you're a stark guy as well and very blunt, is we go through something like this, and we've got more than 700,000 Americans dead, millions around the world. And, I just watched Alex Gibney's show the other day that kind of lays out the sequence of decisions and what happened. And it kind of makes you sick in a way. And so, I think we're storytellers. And if you're a storyteller, there are sometimes villains, sometimes there are heroes. There are lots of shades of gray. But if the villains aren't held up, and if you don't know who the villains in the story are, then it's very hard to figure out how to do it. So tell us about who some of the villains or what some of the villains were in Preventable.
Well, let me start with who, in my opinion, is not a villain. Everybody around the country who did their very best with whatever information they had to make difficult decisions to balance getting the economy back with saving the most lives. And there are 50 different governors with 50 different approaches. And I'd say 46, 47, 48 of them, even though they took different approaches, were really doing their best. So I think we ought to not penalize people for things that I would call honest errors, honest mistakes. There are also, though, dishonest mistakes, things that are were not done in our best interest. So when President Trump, for example, found out in January of last year that this was going to be a deadly pandemic virus and refused to tell the public about it, in fact, he went to bed every night for 2 months, presumably slept soundly, until the NBA season was canceled, when he was forced, and the stock market was down, when he was forced to come forward and say, yes, there's a pandemic. You think about what was lost in those 2 months, how American families could have protected themselves and responded if the president had done his job. So to me, that's in the category of a hard to forgive mistake, because it was willful. Suppressing science and scientists, also very difficult, and playing politics with a public health crisis. Those are things that probably we should look at a little more skeptically. Now, when I say villainously, maybe that's not the language I would use, but I would say that these are the kinds of things, and we've seen them, that are just where we don't have the common interests of the American public at heart. And I think we should be very concerned about having those kinds of political decisions made on our behalf.
So I guess the big question, Andy, is one where how vulnerable are we to this sort of I don't know what they call it, Keystone Cops, hijacking. I mean, just to hear the hydroxychloroquine story and how that unfolded. I see Peter Navarro is still out basically talking about, why he was right. And you find the fact that we almost came within an eyelash of having a generic drug that is needed for lupus patients and other things taken away from them and used and flooded in other ways across the street to deal with this is just a remarkable thing in the United States of America. And so it raises the obvious question of whether it's about our democracy, whether it's about our healthcare system, how fragile do you think we are? And so when you talk about the future and what needs to be shored up, I just am really interested because I do worry about the second coming, not the second pandemic, but the second hijacking of the system or the wobbliness of trust in science, if you will.
Look, I think where our weak spots are is it's very easy to spread misinformation in this country, and we've got a very willing audience for it. We have people who are, for whatever reason, skeptical of government and susceptible to conspiracy theory and skeptical of expertise. Now, I think the experts and the government ought to take some responsibility for that and say we're partly to blame, we need to do a better job, et cetera. But that's not the whole picture. The whole picture is that somebody on Facebook could literally say virtually anything, and if they hit the algorithms right, they can get tens of thousands or even millions of people to believe them. That is a very susceptible place we are. Now, we have 75, 76 or more percent of adults vaccinated. And in most things in life, 75, 76% is enough to win. In this pandemic, in the case of Delta, it's just not. So the disunity we have, the large number of people who are holdouts, not just to not get vaccinated, but to say that anything they're hearing from science and scientists isn't to be trusted, is a real cost. And I think we've got to go much deeper than the 2016 election or much deeper than the pandemic to get to the bottom of it. I think it's something that is more deep-seated and perhaps has always been ingrained in this society, but has become, over the last 2 or 3 decades, a really powerful part of our society. And that's something that if we do face this again, as you suggest, people, anybody can exploit that, whether it's a Russian disinformationist or whether it's people in our own country who just like to do it for fun.
Let me ask you another question about exploiting or overcoming the divides in society. So we I guess one of the things that I learned from COVID and drilled into was, I was not as aware as I should have been of the disproportionate outcomes in health across racial lines, socioeconomic lines, but I am now really very much aware of that. And COVID, helped highlight something that you just see across sector and sector and sector in the healthcare arena. And so I'm wondering if there are any things that you and the Biden team were able to do that give promise in terms of how you were reaching communities of color to the degree you think you did and help build trust and get them under the tent of vaccinations, et cetera. But are there things that you did that can be replicated, in other parts of the healthcare arena?
Well, look, it's a great question, and I'll give you an example of how one might approach this. It was early on. It was clear that as we had a limited supply of vaccines, those vaccines, as they went out, were getting scooped up by people who had modes of transportation, access to the internet, lived in the suburbs. And we had this sort of vaccine tourism where, white, well-off people would come into black neighborhoods and other neighborhoods of color, and they would get in line and take the vaccines in those communities. And, the first day we opened up a national vaccine site in Oakland, it was packed with people from where? San Francisco. So what we learned is that you have to make an extra effort. You have to actually do this with some focus and some purpose. And so, from then we basically said a certain number of hours need to be reserved for people living in the community, and that made a big difference. We had to talk with people to where they were, because remember, there's, some of us who get paid a salary have a little bit more time on our hands, have transportation, et cetera. But if you're working by the hour, you're cleaning hotel rooms, you're not getting time off. You have to take the bus perhaps to a vaccine site. You're just not going to get yours. And so, if you really want to solve these problems, you can't treat everybody the same and just put a bunch of vaccines out there and hope they get to people. You have to get to people where they are, in their workplace, in church, and reserve hours for people, provide free transportation. We did all of those things, and we caught up. And we nearly eliminated the disparity in vaccines. Now, there are people that would say, well, that's not fair. Why are you making extra effort for some people as opposed to others? But you have to overcome the structural issues. And the structural issues are that there's not medical care available in the community to many populations, Black and brown, rural, low income. And if you don't address it, then those people get left behind.
Well, listen, I really appreciate your candor as always, and I want folks to pick up your book. But I also believe it was either your birthday today or yesterday, so happy birthday. But Andy Slavitt, former senior White House advisor and author of Preventable: The Inside Story of How Leadership Failures, Politics, and Selfishness Doomed the U.S. Coronavirus Response. This has been great. Thank you so much for joining us.
Thanks for having me.
My next guest is Congressman Tony Cardenas of California. He's a member of the Energy and Commerce Committee and sits on the Healthcare and Mental Health Task Force of the Congressional Hispanic Caucus. Congressman Cardenas, it's great to see you here. Tell us how you've got all sorts of legislation in the health field. It's your hobby or obsession, I don't know. But tell us, as you kind of interact with your constituents and they see missing gaps in healthcare that they think need to be fixed, what are you working on of highest priority?
Well, my highest priority is to make sure that we have access to healthcare to as many Americans as possible. Many people have heard about the safety net system. I grew up in a community where we were dependent on the safety net system. In LA, that's the LA County system. But we have affluent hospitals in our community that actually have better equipment. They have reserves, financial reserves, et cetera. So what I'm trying to do in Washington is pass legislation to make healthcare more accessible to everybody, to as many people as possible, while making sure that we're not hurting the system, but we're improving the system overall. So many of my bills have to do with access to medications to more people. Many of it has to do to make sure that the reimbursement rates at the federal level are fair, so that more hospitals and more physicians and more people who practice health will actually be involved in helping people who are dependent on Medicare, et cetera, and other parts of our healthcare system.
Another thing you're doing that I really appreciate, we've talked about it in various other programs earlier today as well, was, whole health also includes mental health, behavioral health, and then what you're working on, the Behavioral Health Crisis Services Expansion Act. I just really feel strongly that ought to be part of the conversation here. And I'm not sure when it comes to reimbursements, when it comes to the way the economics of the healthcare system works out there, that's given as much attention as other elements of health. Am I wrong?
You're absolutely right. One of the biggest problems with mental health is, for a long time, public and private institutions were trying to do their best, but at the same time, honestly afraid to give more services, because the need is so big that once they start giving those services, they get overwhelmed and they get underwater financially because they can't afford to sustain that kind of service when they're not being reimbursed and or they are not given the resources to continue. And then that's been one of the burdens on both public and private institutions. So what have we had in America? The people who were able to get access to mental health services were the wealthy, because they could afford $150, $250, $350 an hour to be able to pay for that healthcare service, mental health care service. Yet at the same time, on the other side of town, in other households, they depended on their system to say whether or not they could get mental health services. Now, everybody for a long time has been able to get physical health services. In other words, to go see a doctor, get a checkup, or if you get a cut or a bruise or what have you, you can see a doctor and get help. But if you have a mental health issue, it was incredibly limited. Now with the Affordable Care Act, we're mandating that the healthcare system, including the insurances and the providers, that they make it accessible. So we're still trying to make sure that the system itself on the ground catches up to that. And we have various bills to try to make sure that we are requiring people to pay attention to the fact that mental health is related to physical health. And it's a holistic solution when it comes to human beings, not just physical health, but mental health are big factors as well.
You know, another big question, I have to admit, Congressman, I don't know if I'm going to get this out right, because whenever I get my head into the kind of healthcare ecosystem, it gets extremely complex really quickly. Lots of different moving pieces and tectonics, you know, in this. But one of the areas I'm interested in is how do you get the equilibrium right in areas like competition, you know, on drug prices, on provision of care in hospitals, the tension between urban centralization and rural care, because it seems like we have to put the lines in certain places. In pharmaceutical area in development, there's a social contract around innovation, and then removing that so you can kind of move and get those costs down. I'm just wondering, in your broad survey of this, do we need to take a look at where the incentives are not working anymore, where we don't have enough competition?
That's a great question. And you just explained how complicated it is. It's not real simple. It's not black and white. If you move one thing, something else is going to have an effect, both positive and negative. But let me give you one example where science has really come a long way. And when it comes to something called biosimilars, we need to make sure that we encourage the innovation of biosimilars and also incentivize the system to get away from both physicians and patients dependent on prescription drugs that are not within the biosimilar space. Biosimilars have been approved by the FDA. That's going to bring a lot more competition into the space, which means it will bring prices down, make it more prevalent and available to more people across the spectrum. Like I said at the beginning of my comments, I'm working on, and many of my colleagues are working on, making sure that healthcare is available to as many Americans as possible. And when it comes to prescription drug pricing, that's something that is really, really upsetting the American people. And right now in the Build Back Better Act, we do have a piece of legislation in that large legislation to bring down drug prices so we can have a better negotiable system when it comes to the federal system. So those are some examples of what we're trying to do here. And to me, we need to make sure that we take advantage of science as much as possible and make sure that we have better competition and we incentivize both the physicians and the patients to be able to have access to more, drugs that are going to be solving their issues and increasing their quality of life. And actually, in some cases, these drugs are actually saving lives.
In the biosimilar case, Congressman, Europe has so many more biosimilars approved than the United States, and the FDA has begun to pick up the pace a little bit, but it still lags way behind Europe. And I guess, though, as I've understood it, one of the areas or gaps is in the way, the FDA requires all sorts of data, human data, and part of that data is held by, the property rights holder of the drugs that the biosimilars are seeking to come in and not replace, but just sort of add an adjunct in there. And it's also, again, really important within patient-centered medicine and precision medicine to be able to get some of this right and tailored in. But part of it is data sharing, and part of it is trust across different parts of the industry. What do we do to do that? Is that something that has to be legislated?
Yes, unfortunately, it does have to be legislated. It's a delicate dance, like I said. It's very complicated. And the bottom line is this. Sometimes you have cases where hundreds of millions or billions of dollars are invested in a product that comes to market, and it is improving the quality of life. It is effective. And like I said, in some cases, saving lives. So what happens is those drugs are available to be on the market for a certain period of time. After that, we're supposed to have a system that opens up the competition so that others can actually make competing drugs to have an equal ability to actually improve people's lives. But at the same time, you pointed out something very important. We have to figure out better ways to make sure that that information is shared so we can get that competition into the system sooner than later. Nobody wins when people are allowed to drag their feet, and we're actually preventing good drugs to hit the market sooner so that it can have more access to more people. And that's the main thing that I need to emphasize. We have a great system in the United States when it comes to the FDA is the most respected approval organization on the planet. Yet at the same time, we can improve it. And one of the ways to improve it is to make sure that we have better cooperation, just like you described.
Well, thanks very much. Just finally, I know that Build Back Better has not passed yet, and I'm also have not read the bill, although I should. Not sure where all the lines are written there. But, when it comes to the health provisions, what are you hopeful changes, if anything, if Build Back Better becomes law?
Well, one of the things is I hope that we have a system that starts the ball rolling forward where we have more negotiation which will flatten the prices of prescription drugs, make it easier for American citizens when they go to the counter to not be in a situation where they are just in pain, not physical pain, but mental pain, thinking like, I can't afford that deductible. So everybody involved in the system needs to make sure that they're at the table, actually making sure that we have a system where when somebody's prescribed a drug and they want and are willing to take it, they're going to buy it at that counter and not say, I can't afford it, and leave it on the counter. That's something that's happened in too many parts of our country, and that's one of the things that we're trying to improve upon in the Build Back Better. And after that, we're still going to continue to do more.
Well, Representative Tony Cardenas of California, member of the Energy and Commerce Committee, I know you were down on the floor voting, and I'm really grateful that you kind of snuck out of that to come give us some of your thoughts today. So thank you so much.
Thank you. Pleasure to be with you.
Joining me now are two health economists for a conversation on cost, on value, and transparency when it comes to drug pricing. Antonio Chacha is the CEO of 46 Brooklyn Research. Sounds like a cool outfit I'm going to have to visit. A nonprofit organization working to improve the public's understanding of drug pricing data. And Kirsten Axelson is a visiting research fellow at the American Enterprise Institute. Her work focuses on domestic and international pharmaceutical drug policy. She also consults with biopharmaceutical and other companies. Antonio and Kirsten, thank you so much for joining us. Antonio, let me just ask you this. You know, I've always been a fan of those old kind of schoolhouse rock shows, you know, how a bill becomes a law, and in the end, hey, I'm a law. But I'm also, I figure I got to make a schoolhouse rock show on how a drug gets a price. You know, like, so what would be on your schoolhouse rock show on how a drug gets a price?
Well, I wish it would be one show, right? I think we'd be looking at various seasons of that show. Unfortunately, in the drug supply chain, we have a lot of different ways that we can actually quantify what price is. And that's where the opportunity for excess comes in, because unlike any other product that we purchase out in the open marketplace, a drug can have various prices that can exist at various stages in the drug channel. And when somebody is actually purchasing that product, their exposure to price can be different from the very next person that purchased it. And so because of that, you have a tremendous amount of opacity. And what I like to usually say is anytime you have more than one price, there's no such thing as price.
Fascinating. Well, I mean, I know, Kirsten, that Antonio has called America's pricing system the most dysfunctional pricing market in the world. What do you think?
I mean, the prices for drugs in the U.S. are similar to the prices for other types of healthcare in the U.S. There's a lot of opacity, and the prices for physician visits are in many cases controlled by the federal government. So I don't think just the federal price controls are going to solve a system that is very, very difficult to parse, as Antonio, I think, has correctly identified. You know, when a drug is launched, we have the worst, most incomplete data about it we'll ever have, right? We have the clinical trial data, which comes from a very artificial, sanitized group of patients. We have never seen the federal government invest in making real-world evidence available. If we really want to put the pharma companies back on their heels, we should have interconnected data where we can evaluate these drugs and see if they're doing what they say they can do in real-world settings, in different types of patients, in diverse populations. And to me, that would be a way you could really, really see whether these drugs are worth the prices that are being charged, whereas now we have very little information.
Well, I mean, you know, I guess one of the areas of concern, because I have really spent a lot of time with people on I wouldn't even call it both sides of debate, because there seem to be multiple sides of the debate. But Antonio, you know, one of the things that I do think is compelling from the pharmaceutical industry side of this is that they do take a lot of risk. I mean, there's this great film, you know, where Lilly invests $1 billion in an Alzheimer's drug, and it didn't pass the trials. It funded their. I've often told pharmaceutical companies, why aren't you, rather than just marketing your successes, also marketing your failures, so that people understand, you know, the give and take. And I think the other dimension of it, you know, which I find interesting, is that there are a lot of other parts of the system that add price, not just what the drug company says. But so I'm wondering whether that framing I'm trying to bring to this, you know, is some defense of this. Not to say that we shouldn't have greater competition out there, which I believe we should, but aren't there misunderstandings as well about opportunity and risk in innovation and drug development?
Well, Steve, it appears that you're talking about the nuance of how drug pricing and drug incentives actually work, which unfortunately I think is lost upon, you know, a lot of those that set narratives around drug pricing reform. There's no question that you've got, you know, problems with drug pricing, There's no question that we have problems with transparency within the drug channel. But to your point, yes, for every success, there could be, multiple failures. And regardless of whether there's more successes than failures, what really matters is how we want our system of incentives designed. We want drug makers, we want those who invest in drug companies to have adequate incentive to continue to bring new innovative therapies to marketplace. Hopefully, fingers crossed, we hope that they're actually innovative. And then we hope that they bring about cures or bring about better forms of treatment that exist in the current marketplace today. But as we look at how to calibrate, how to fix our drug pricing problems, it feels as though we're just taking a very top-down approach, a very surface-level approach, without understanding that if we don't like what the system is currently yielding, then perhaps we need to change the incentives of what it's currently yielding. How do payers, whether it's government, insurers, PBMs, you name it, if we don't like what we see, if we feel like we're getting poor value, then we need to calibrate the incentives that drug makers have in order to get essentially more of what we actually want.
Wow. Kristen, on your side of this, you have an interesting role that I want to highlight, and I guess I want to thank you for it, because I think it sounds good. But you're Secretary of the Preparedness and Treatment Equity Coalition, which, if I take it at face value, is about equity and preparedness. So what are you trying to fix? What problems are you trying to fix out there, when it comes to this industry and the provision of health to patients?
Absolutely. I mean, me and my co-founder, Benson Shu, have both worked in healthcare for a very long time. He's on the provider side, and we see that behavior follows metrics and payment and reimbursement. There's been, an increasing focus on increasing equity in healthcare delivery. Our health outcomes should not depend on our race or ethnicity, but yet there's still, pervasive and widening gaps, which were only made more stark when we saw the impact of the pandemic, particularly on people who had underlying cardiovascular and metabolic conditions. So we're an organization funded by life sciences companies, and we fund research that is implementable, different ways to deliver and pay for healthcare and measure healthcare value that is specifically focused on increasing equity in healthcare delivery.
Well, fascinating. On the other side of this, I'm sort of interested, Antonio, on what you think are the levers, because again, this is a very, very opaque topic to many people. We would hear Donald Trump, talk about negotiating with, companies and getting prices down. I've heard that just from the Congressman Cardenas a minute ago, as part of the Build Back Better plan. What do you think are the realistic ways in which to get drug costs lower? What are the easiest, lowest hanging fruit in that struggle?
When I think of low-hanging fruit, I think of a lot of the waste that lives within the drug channel itself. A lot of our research is concentrated on what Medicaid programs pay for prescription drugs, what pharmacies are compensated for prescription drugs. What we find is there's a tremendous amount of waste from drug maker to wholesaler to pharmacy to PBM to plan sponsor. And, not to pick sides on it, because we certainly have a lot of issues on the drug maker side, but drug makers produce drugs to flow into a drug channel, which begs the question of what are the incentives that the drug channel provides those drug makers. We've done research, dating back to look at Prilosec and the conversion over to Nexium. Nexium is not necessarily a bad product, but its value add to the system was extremely small relative to the drugs that were already on the market for PPI. PBM signed up, government programs signed up saying, yeah, we want that drug, even though it was significantly more expensive than the drugs that were already on the marketplace. The message sent to the drug makers making those drugs is, give us more of them because we'll cover them, even if they don't provide significant value relative to what was already in the marketplace before them. So when I look at, what I'd like to see as far as, drug pricing reform, it is, making sure that if particular products provide little value relative to what's on the marketplace at the time, we need to make sure that a system doesn't provide that incentive to drug makers and instead focuses it more on more relevant treatments and therapies. And then moving down through the channel, making sure that arbitrage isn't being exploited by PBMs, pharmacies, wholesalers, et cetera, because to me, that's where a lot of the low-hanging fruit is available.
Thank you. Kristen, I wonder if you could kind of give us a lesson, because as I've looked at it, and if I were to look at, pharma material, which I also read and look at, they show that in the aggregate, drug prices have just not, according to them, have not risen. That there is a a kind of view out there about the overall cost of healthcare. Their argument is that people are feeling and sensing this more because of changes in the insurance industry and deductibles and that dimension. And I'd just love to hear where that is true. And then another side of this on the generic side has to do, as we were talking about, biosimilars and other, products, complex molecules and others coming onto the market, and how you get the transition from the sort of, intellectually property, protected innovation, and then moving after a certain number of years to something where that product, because it's in the health space, becomes available on mass basis by producers that are in the generic area. I'd like to know what the fault lines are in that, what has come undone, if anything, in that equation, and what is, from your perspective, fact and fiction when it comes to pricing?
The vast majority of the market is working well to deliver low-cost generics that are not in short supply. More than 90% of the drugs that are dispensed in this country are generic. And there are a few that get a lot of attention that are in short supply. You have big price increases, but overall the system is working incredibly well. And in fact, drugs are the only part of the healthcare system that has a built-in cost savings. You don't see the cost of surgery declining after 12 years or 11 years on the market. So, and when we think about patient out-of-pocket costs, there are a small number of patients who have devastatingly high and unaffordable out-of-pocket costs, and their out-of-pocket costs need to be addressed. And that's an issue of both the price of the drug and the insurance benefit design. There's just more expensive drugs because we've seen more transformative therapies. On the other hand, if you look at adherence, even with generics, which are very low cost, sometimes less $0 or $5 for many cardiovascular drugs, the adherence is not that much better. Still, half of people drop off taking these drugs after 6 months. So we can't say that all the problems are because of the out-of-pocket costs. It needs to be addressed, but we have a larger issue in that we are wasting a tremendous amount of money and life by not finding better ways to get people to, understand the value of staying on these low-cost therapies and really identifying sort of the behavioral nudges that would help people adhere with the preventive care, which is widely available and fairly inexpensive.
Well, thank you very much for that. And I guess, Antonio, what I would like to ask just on the other side of this is when I talk to the generic side, and I kind of look at, what are the big drivers that you think would help bring costs down? They say, look, just let competition happen. So what are the inhibitors to competition that we ought to have on our dashboard?
Well, the generic manufacturers are right. We study generic drug prices more than we should. And what we see is a very lean and mean marketplace where there are a lot of manufacturers who compete with one another to beat down the cost of those generic products. You have an incredibly functional and a highly competitive marketplace on the generic side. Then we turn over to the brand sector, and everything goes the exact opposite. Competition actually makes prices go higher and actually forces the list price even further and further from the real price through the rebating process. You have a really perverse system on the brand side where we would think competition would lower prices, but it actually ends up doing is oftentimes having the opposite effect. And look no further than insulin, where the net price that a manufacturer might take in for an insulin product might be 13% of what the actual list price is. And that's a symptom of a marketplace that encourages high list prices and high discounts rather than actually lowering the list prices as a means of competition.
Well, we're going to end it there. I think it's a fascinating conversation on topics that make my head spin with all the detail. But Antonio Ciaccia, CEO of 46 Brooklyn Research, and Kirsten Axelson, Research Fellow at the American Enterprise Institute, thanks so much for joining us today.
Thank you.
Thank you.
Joining me now, our panel of experts on patient-centered care. We're going to talk about patients because patients are at the center of all this stuff. Christelle Marchand Apriliano is Chief Advocacy Officer for Beyond Type 1, a nonprofit organization with a mission to unite the global diabetes community and provide solutions to improving lives. Ted Okon is Executive Director of a Community Oncology Alliance that works to ensure cancer patients receive quality, affordable cancer care in their own communities. And Linda Goler-Blount is the President and CEO of the Black Women's Health Imperative, a national organization focused on Black women's emotional, physical, and financial health. Welcome all. Luckily, this is like an alumni group. You should all meet each other because you've all been here before. So it's terrific, and I think we've met in different settings. But Christelle, we were just hanging out yesterday together and talking a bit about diabetes, and it's just very much in my mind in terms of all the dimensions of really good people out there who want better health, and sometimes the cards are stacked against them in various ways. And we're not moving things in such a way, in my opinion, that's solving that. And so I want to ask each one of you as we get into this to talk about the communities you're trying to advocate for, and what does the rest of the healthcare community and the policy world need to change? What are the blind spots they have in understanding how to put patients first, how to get patient-directed care, and make it really matter and not just be words? Christelle?
Steve, thank you. We just celebrated 100 years since the discovery of insulin. And yet we just had a previous panelist talk about how we've got some very perverse incentives that are preventing the lower out-of-pocket cost for the list price of insulin. And so for me, when I talk about the U.S. healthcare system, it's failing. It's failing to help when it comes to patient-centered care, especially when it is about drug pricing and access. The reality is that I used to say that the system is broken. And I think that anybody would say that the system is broken, but let's be real. The system is working incredibly well for a number of entities within the supply chain because they're making a profit. And the realization that they're making the profit on the backs of patients, and especially when it comes to insulin pricing, which is a discussion that numerous congressional hearings have happened on this. We've talked about it. Patients are not part of the system. We simply pay for it with our health. And Gary talked about this in the previous session about reducing patient risk. And Dr. Harris talked about improving patient outcomes. You can't do that when the cost of a drug that keeps us alive is out of reach for many individuals. List price in itself is a lie. List price just obfuscates what I believe is perverse incentives of rebates and fees that are demanded by an entity within the supply chain, which Ted talked about this morning at a hearing. And it's demanded by PBMs to put drugs on formularies. We're not making decisions, so we can't even control the cost of the drug that we need.
Well, thank you. Ted, Christelle just mentioned you were testifying before Congress today, and what did you tell those folks? I know you were talking about pharmacy benefit managers. We call them, PBMs. And what is the element of change or salutation or concern you have on PBMs?
Yeah, thank you, Steve. I'll continue the theme today. I participated, I was a witness in a 2-hour forum called by the Republicans on the Oversight and Reform Committee, Ranking Member Comer. And really, it's so aggravating because I shared with the members of Congress that literally just this morning, I read an email from a practice where a gentleman was diagnosed with metastatic prostate cancer. So his bones, his lymph nodes were lighting up. And after going through a prior authorization process, the practice had the okay to give him the oral drug. But they couldn't because the PBM/insurer said, no, it has to be delivered by this specialty pharmacy. That specialty pharmacy required a whole new prior authorization. And as if this wasn't bad enough, he went through it went through a specialty, a mail order to another mail order. So he had to get his drugs in the mail each time with a prior authorization. Steve, it took him 3 weeks. Imagine, you and I are guys having prostate cancer, and it holds for any cancer, but especially prostate, your everything's lighting up. You want to get that medication. And the kicker is, after 3 weeks, he finally got it from the mail order pharmacy, but the dosing was wrong. So literally, he's supposed to take 4 capsules 1 time a day at the same time. And then next, literally the PBM said, no, take 1 capsule 4 times a day. So it is dramatically different. And this is this is what we're facing. And Christelle and Lynn and I just before had this little conversation, and I said, who gets disadvantaged most are people who are in the most disadvantaged position, whether they be older, whether they be on what scale on the socioeconomic scale, but these are real live Americans. And when you talk about trying to get patients treated in their own communities, it's these middlemen, especially these PBMs, that are now the same as the insurers, that, Christelle said, they get in the way of patients getting treated. And it is just about a crime.
No, I can feel the passion there, Ted. And as I'm just listening to you, I was going to ask about accountability on this, but the victim who waited weeks and probably later now to get the life-saving therapies and drugs that they need, they can't wait like this. And so, I am old enough, folks, to remember how we used to talk about the Soviet Union, how we used to talk about China before it was a big, these are the kinds of things we would joke about other societies not being able to produce. And it's happening in this country. So I'm on the editorial side of this operation, I can say that. But Linda, again, when Ted was just speaking, I don't know this individual that Ted is talking about, but I do know that the experience of that individual is probably 10 times worse in some of the communities you're dealing with, who are, in disadvantage, where power, the disproportionate elements of power in the healthcare system screw you. But tell us about what you're trying to turn around.
Yeah, it's fascinating, disheartening, maddening how much of this burden we put on patients. We were semi-joking before we came on that we're supposed to be patient-centered, provide patient-centered care, and Ted said I had the wrong P. It was really profit-centered. What happens is we put the burden on the patient to be the advocate, which means they've got to be a researcher, a pharmacist, an oncologist, all manner of specialists, a health system CEO, to know the questions to ask. That's not fair. And you're right. If we go back 35 years to the Heckler Report, where the Secretary of Health and Human Services, Margaret Heckler, said, we've got a problem. We've got disparities in health outcomes between African Americans and white Americans. Come forward now to 2021, those same disparities exist. And in fact, many are whiter now. So we've got a system that does not put patients first, that does not center patients. We've got a research process that doesn't include patients, so that we end up with therapeutics that don't work as well in certain populations. And technologies. We saw this last year with the pulse oximeter, with dexamethasone, not as effective in Black patients. We've got a pipeline that has not changed in 40 years. The percentage of Black and brown physicians hasn't changed since 1980. The percentage of NIH-funded researchers at the highest level, those that are Black and brown, still under 2%. So we have this system that's not set up for people who are low income, for people who are in rural geographies, for the Black and brown population, who from the moment they walk in a provider's office sometimes are made to feel that they're unwanted. And what happens in the instance that Christelle is talking about and Ted is the patient gets blamed. Well, why, Mrs. Brown, haven't you been compliant? Well, because it would have taken 2 buses and a subway and 3 hours to go to get this medication, and I have a job, and I didn't want to lose my job. So we need providers, we need system leadership to understand the lived experiences of their patients and then organize the drug development, drug therapeutic management, system care availability around their lives so that they actually can participate more fully in their care. Because it's not that they don't want to, but we put up barriers that make it practically impossible at times.
Wow. Christelle and Ted, I want to ask you, along those lines that Linda just talked about, one of the areas, look, I'll just be honest, folks, I lost my mother to breast cancer, right? So she fought cancer for 15 years. She was in Bartlesville, Oklahoma, is where she started out. Then she was in Dallas, Texas, then Johns Hopkins. I have to tell you, this was years ago, but the way gravity worked around her situation was different in each one of those places. The information she was given was different in each one of these places. And my mom was an incredible woman who was trusting her doctors and what she was told. I wish she hadn't. I wish she had been a warrior. I wish she had not trusted everything she had. I wish we had been more literate and gone out to do other things and become more of a fighter for her health in the system. I think we were too passive. So I'm just sharing this personal story. And so it is an interesting story. I talked to Christelle yesterday about the challenge of we're expecting patients to not be passive, but to become active, empowered agents. And if they don't, they're going to get screwed. Tell me where I'm wrong, Christelle.
You're not wrong. But we also need additional advocates around us. And we need bold action by elected officials, right, who are willing to champion for lower out-of-pocket costs, for better outcomes, to make sure that for our overall health, that we're able to reduce the barriers. I mean, the crazy hoops that all of us have to go through. I've had type 1 diabetes for 38 years. If I don't advocate every single day to make sure that I am taking care of myself, the blame falls on the patient. Right. And the reality is that, especially when we're looking at costs, right, and the ways to lower out-of-pocket costs for people with diabetes, we have no say. And so we have opportunities right now through policy and through some bills that are currently on the Hill that I think will help change that paradigm and help us have greater opportunities to actually have resources to help. Beyond type 1, we have getinsulin.org, which is aggregated resources. But it's a tool. It's not a solution for list prices. Right. We have to address the list prices. We have to put generics and biosimilars on the lowest tier. And that's not just for Medicare Part D, which is the bills that are out there right now. But I mean, to kind of put it on the PBMs to say, it's not a bad thing to help patients, not sacrificing the huge profit that you're currently making. Right.
Ted and Linda, I'd like to get quick thoughts from you, and then we have a question from the audience. But Ted?
Yeah, well, I'm gonna address something that Linda said. I think, the good news is, if there's any good news out of COVID, is that everybody's talking about health disparities, right? I mean, even though we should have been talking about them a long time ago, and we should have been fixing them and addressing them and all of that. The bad news is there's a lot of talk, but there's not a lot of action. And I can tell you that from the COA perspective, we are jumping into action. Yes, we put out a statement. We need to do this about health disparities, and it runs everywhere, as Linda said, from the clinical trial process to the actual care in the community. Right. We have 2 pilots that are going on now. One that is about no patient left behind, Dr. Kasha Patel in South Carolina, and it is guaranteed that no patient, I mean no patient at all, will be left behind. They will be actually tested with biomarker appropriate testing and making sure that no one falls through the cracks. We have a very different pilot that looks at social determinants of health, literally from the second the patient walks in the door, they've been diagnosed with cancer, and we're trying to actually even work backwards to the primary care side in Houston, Texas, looking at the idea of let's solve this. And the last thing I want to say, Steve and Linda will have to have a conversation about this, but we've been doing a lot of research about the fall-offs in breast cancer and lung cancer and colorectal and prostate screenings due to COVID. We've specifically now zeroed in on breast cancer and looked at screenings, mammographies, at not only pre and not post, but hopefully we're coming out of COVID, but where we are, and also looked at it along socioeconomic lines. And we actually have a manuscript. I'm going to be a co-author on it that we hope to get published soon. And it shows some of the things that Linda just talked about in terms of disparities.
Well, thank you. Linda, I'd like to give you a snapshot here, and then we'll take a question from the audience.
I think something that's really important to note is around drugs. Is drugs are valued, and whether or not an insurer covers a drug depends on how that drug is valued. Right. But we don't often take the lived experience of the patients into consideration when coming up well, not we, that organization that does the valuation, consider the lived experience when coming up with the value. So there can be drugs that are effective for a population that are deemed not as valuable, and so they're not available to the patient. And so to Christelle's point, yes, we have to advocate, but there are some things that we just can't know. There are drugs that could help, but we'll never know about them because they'll never be covered by insurers.
Wow. Oh, let's take an audience from a question from Elaine Bleckman. Elaine?
Hi, I'm Elaine Bleckman, CEO of redkangaroo.us. My question is, what innovations are needed in health information technology, provider-facing electronic health records, consumer-facing health tech, to prepare for the biggest coming threats to public health and healthcare delivery? Thank you.
Thank you. Why don't I go to Christelle? We'll take a quick snapshot from each of you. Christelle?
Sure. So for us, we think that at least for the diabetes population, we have a lot of technology, but people aren't able to access it because oftentimes we're starting to see, Linda touches upon this, there's implicit bias. There is lack of the ability to access this technology. And so you can't incorporate the technology into electronic health records and have that mobility without actually addressing the fact that we're not getting to the right people and making sure that individuals with diabetes have access to the technology that they need. That's an entirely separate discussion. I'd love to come back and talk about that.
Well, we will have you back. Ted?
Yeah, I think part of the problem is there's a lot of technology out there. Some of it not only can be more user-friendly, but what I'm concerned about, there are silos. So when you basically go and you have your health record, you don't own your health record. I actually just read an article of saying that your health record shouldn't be owned by everybody who thinks they own it, including doctors and hospitals, et cetera, insurers, but it literally should be your health record. It should be transportable. So you should have access regardless if you get your employer or whoever, you switch from one insurer to another, it should be transportable. And I think that's one of the biggest problems is that the entities, and even physicians, oncologists, think, well, we own your data, whereas basically your data, your health record is your health record, and it should stay with you no matter what, just like the fact that, I switch carriers, my cell phone number is going to stay with me.
Linda, you get the last word.
I would say the innovation we need is to make technology inclusive. I published a paper 2 years ago called Overbooked and Overlooked that looked at bias that's built into the algorithms in the scheduling system of electronic health record systems. And it made Black patients, the system was double and triple booking the Black patients, so they had to wait longer. So sometimes they just left, which has implications for their care. But of course, nobody Black was involved in developing that algorithm. And we've got dozens, if not hundreds, of examples of technology that was developed by a very small group of people, that was not inclusive, that was not tested on anyone of color, that turns out not to work for them. So while we may need some innovation, we need to make what we have more inclusive so that it works for everyone.
Well, listen, I am so heartened by all the work you're doing to kind of keep people in the equation, because I think they could fall out if all of you were not doing what you're doing. But thank you so much to Christelle Marchand-Apriliano, Chief Advocacy Officer for Beyond Type 1, Ted Okon, Executive Director of the Community Oncology Alliance, and Linda Goler-Blount, President and CEO of the Black Women's Health Imperative. Great to talk to all of you, and I hope we can keep doing this again. Thank you.
Thank you.
Thank you.
My final guest is Senator Bill Cassidy of Louisiana. He serves on the Health, Education, Labor, and Pensions Committee, and he's the ranking member of its subcommittee on children and families. I spoke with Senator Cassidy just a short while ago. Take a listen.
Senator Cassidy, thank you so much for joining us. Look, our job today in these discussions we've had is about envisioning a different healthcare world, a different way that people get health. And I sort of feel like there's this tension between little incremental steps and big strategic leaps. And I know that you've been involved in so many different efforts on obesity, on maternal mortality, on telehealth. Can you tell us what you think are the most important opportunities we have to transform healthcare in this country?
I think I'll go in two different directions. The first is, how do we bring technology to the person where she lives, as opposed to requiring her to show up? Our Connected Moms recognizes there is a disparity and death after pregnancy.
And so Connected Moms is a program, right? Connected Moms is a program? Okay.
Name of a bill we've offered. It would allow her to stay at home. And there's racial disparity associated with this, socioeconomic disparity. It would allow her to stay at home, for example, and get her blood pressure monitored and this to be transmitted electronically. Really very simple. But it would make a big difference for someone who's in her 9th month of pregnancy taking public transportation to get her blood pressure monitored, maybe in where I live in Louisiana, August. What a difference that would make. So why don't we bring all this technology we have to where she lives, as opposed to expecting her to come and kind of participate when she comes? I can give different examples. Everybody's familiar with the impact of telehealth and telemental health. And so again, we should, making sure that it's not abused, nonetheless make that available. That's number one. The second is to begin to do something serious about obesity. Obesity drives an incredible amount of the healthcare costs in our nation. Whether it is the heart disease, the joint replacements, the strokes, the cirrhosis leading to liver transplant, gallstones, I could go down a list. And yet it's been something that has continued, it has continued to be, how do you put this? The incidence of obesity over the last 3 decades has climbed dramatically, but we've not really been able to address it equally dramatically. And so we have the Treat and Reduce Obesity Act, which would allow Medicare to begin covering pharmacologic therapy for obesity. We think this could have a huge impact in addressing morbidity, mortality, and cost of care.
You know, I know, thank you for those. And I completely agree that, you know, one of the things in obesity care that we often don't think about is it also tracks with some of the socioeconomic differences and divides in society. We have a lot of and the comorbidities. When you look at the death rate from COVID, that often was, you know, laying over. You don't need me to tell you this, but I do want to raise the issue of how we improve access in the healthcare system. You worked in the sort of charity health system in Louisiana for 25 years. What are your insights there? What should we as a nation be doing that you were doing down in Louisiana that we should learn from?
I do think telehealth is a major advance. So when I worked, I did a lot of work caring for patients in prison. Now, to go to a prison, at least in my state, you may have to drive an hour or an hour and a half away from where your practice normally is, an hour and a half back. That really is kind of a law opportunity cost associated with that. If you have the specialist who is in a more distant city, quite often that specialist couldn't arrive at all. So we began to implement telehealth 15, 20 years ago, made a big difference with the dermatologist looking at the rash, the nurse right there to interpret a finding, to report a physical exam. Yes, it's a little bit bumpy. It's not entirely flat. Yes, I'll look here for you, to move the camera around. And it brought specialty care to a setting which ordinarily would not be the case. That is what the COVID pandemic has precipitated in society writ large. The degree that we can do telehealth or telemental health could really move access to specialized care dramatically higher. And that will be a silver lining of the pandemic.
You know, another dimension of the healthcare system, which you just mentioned, is pharmaceuticals and you know, different innovations that are out there to begin addressing both chronic problems, but other ailments. And one of the areas there's been a lot of divides between, say, Europe and the United States is in areas like biosimilars or complex generics, or a whole range of new drugs that could come online. And I'm just wondering, from your position in the Senate, you know so many doctors, there's so many doctors abounding in the House and Senate now, but I mean, what is your sense of competition in America? Is it where it should be by way of getting us into the next arena of drugs? My sense is there's a sluggishness. I don't know if I'm right, but I would love to get your perspective.
Sluggishness is the perfect word. And the reason it's sluggish is multifactorial. And speaking now specifically regarding biosimilars versus originator drugs, the originator companies have been able to prolong the exclusivity of their product being used long past the patent expiration. They've done this through arbitraging various laws as well as kind of manipulating market dynamics. And because of that, we continue to pay far more for biologics than we should, if you look at, oh, wait a second, it's been off patent for 10 years, but we're still paying this much. So that's going to take it's going to take legislation. And that I think is very troubling. We want to pay for innovation, but we don't want to reward people who are not being innovative. Rather, they're merely arbitraging laws set up to protect innovation. And that's what's most troublesome. Again, the very law to promote innovation is being arbitraged, not for innovation, but to actually keep innovators out of the market. That's what concerns me right now.
I want to ask you a big question. I mean, I tell people I want to ask a meta question, but now I can't do that given, Facebook's new title company. But, a big question about the overall health profile of America. When you see what COVID has done and the impact that COVID has had there, I know you've been working a lot on mental health. I've talked to Senator Blunt, Senator Stabenow, others that have been highlighting this as well as yourself. I'm just wondering, do we have a holistic way to include mental health and part of whole health, if you will, as opposed to pushing it off to the side and looking at it as this other thing that needs to be treated sort of like an orphan on the side? I don't know if I'm expressing it right, but I know that you have real strong thoughts that mental health is as much a part of our health as our liver.
Yeah, I'll first take off on that, then answer your question in somewhat maybe divided way. Everybody watching this has someone either in their family or in a close circle of folks they knew or once knew with serious mental illness. I do, or did. And we all do. Now, it becomes something that people almost don't discuss. One, you just maybe don't feel a need to. Another, there's almost a little bit of an embarrassment at times for people to bring it up. So I do think, one, we have to acknowledge how widespread serious mental illness is. If you add addiction, there may be whoever's out there saying, well, I don't really have anybody who's seriously mentally ill. I know. You add addiction, they absolutely know. One example just comes to mind, and I'll say it because it's so telling. A very beautiful woman I went to high school with. I just remember she was so pretty. But she walked down the hallway, always facing the wall, kind of knocking her fingers against the wall, had no friends. So she was the kind of person that you would expect boys be asking her out every Friday night. She had no friends. Well, I saw her later as a patient, 30 years later, and she was seriously mentally ill, but someone knew it, but no one intervened. So I use that to say that we actually now have some programs that will go to that adolescent or that young adult and wrap her around with all the services she needs after her first episode. Hopefully that her first episode is her last episode. And in a scientific method, these have been evaluated and they work. That's a good thing. Now, there's another set of the issue that we have not holistically enough. We cannot but notice that economic dislocation has led to a higher rate of addiction and other things that then become a co-diagnosis with serious mental illness. So now that may be beyond the scope of healthcare. Now you're beginning to speak about society. How do we address these issues that are more broad?
That's a powerful framing there, and I really appreciate it because I also think we need to talk about these issues, and I just hate this stigma that hangs around, whether it's obesity, whether it's mental health. You're not going to solve those problems. But I guess lastly, Senator, and hate to put this responsibility on you. I know you try to work across the aisle all the time, and I hate asking partisan questions. But if you were to kind of look either at the blind spots the last administration had or the blind spots this administration under President Biden has on how to approach healthcare and to achieve greater overall health in the country, what do you think the biggest levers are that we ought to play? I know telehealth and paying for that, getting in the way is one, but what are some of the other dimensions that we can think in big ways that either Republican administration or Democrat administration ought to have on its dashboard that you feel it has not been there adequately?
I'm going to give credit to both administrations. One, we have to make healthcare affordable, and because otherwise, eventually it won't be affordable for society or for the individual. And the last administration made the first initial attempts to inject price transparency. I think price transparency has the ability to revolutionize affordability. So they actually made the initial attempts. And this administration has attempted to strengthen some of those rules. We've got a long way to go. But the fact that we're actually making progress is notable, hopeful, and hopefully we can build upon in a bipartisan way.
Well, thank you. Well, finally, I'm going to ask you a question I asked one of your House colleagues, a Republican member, Michael Burgess of Texas, who's also a doctor. And I said, Michael, do you prefer to go by doctor and be known as a doctor, which he is, or do you prefer to remember, representative? And he says, well, let me tell you, doctor polls much better than House of Representatives member. Let me ask you about gastroenterologist or Dr. Cassidy versus Senator Cassidy, which plays better in Louisiana?
Well, usually I go by Bill, but because one, I'm not on a pedestal. But secondly, being a physician is an incredible privilege. And taking care of the patients whom I took care of, we still see each other and we still communicate. And it's just a connection that can never be broken. It's an honor to be a senator, but I prefer being called doctor if somebody wishes to use the title.
Well, I love your Twitter handle. It says gastroenterologist, if I'm saying it correctly, who happens to be serving in the Senate right now. So Senator Bill Cassidy, gastroenterologist, Dr. Bill Cassidy, thank you so much for joining us today.
Thank you, Steve. Appreciate it.
That brings us to the end of our program today. A very big thank you to Beatrice for its support of these great conversations. They were really great. And all of you attendees for joining us. For any of you who missed this program today, we're going to have this entire video up on our website shortly. It's great to check out, watch again, share with your friends. I'm Steve Clements. Be well.